Well, a very good afternoon, everybody. And I think we will start today's session. Dr. Deepika Saroha is the faculty for today. She is assistant professor of neurology, and she has been continuously taking a lot many lectures at our CMEs pertaining to neurology and other topics. And very sought after speaker. I will request Dr. Deepika to please start the day's proceedings on altered mental status, which is a very important aspect of clinical medicine. Dr. Deepika, please.
Thank you, sir. So after the last session that I have taken physically, it was a bit of heavy topic. So this time I have kept it very simple so that not just postgraduate, undergraduate students can also understand this. And this is basically the brief interface for a patient with altered mental status, be it at the periphery, be it at your hospital where you are encountering such patients. So to start with, wait. Yes, to start with, the objective of today's presentation is to recognize the history findings which are suggestive of different causes, and along with that the physical findings which help us to differentiate what are the main causes of altered mental status. Why do you want to know the causes? So that we can treat those patients, we can segregate those patients on the basis of severity, and if at all they are needed to referred, then we can refer those patients and we can bracket them into high risk patients and high risk causes of altered mental status as well. So through this presentation, we'll like to briefly touch the Glasgow Coma Scale. You should be knowing what is AUPV score, recovery positions that should be administered, oxygen administrations, IV cannula administration, IV fluid resuscitation, snake bite if that is the reason, and spine immobilization in patients who have a history of trauma. So to start with, what is altered mental status? It is basically a range of presentations where the patient can present it suddenly or gradual changes in behavior. Patient can be disoriented, there is confusion, and to the extreme, there can be a state of coma. So these conditions can present because of any disorder that affects the brain secondarily or primarily affecting the brain itself. There can be a chronic psychiatric problem or dementia. These should be ruled out in any patient who is presenting to us with AMS. AMS is a well accepted abbreviation for altered mental status. Delirium always require a full assessment and always take help of the bystanders or family member about the baseline mental status of that patient. So the goal of this presentation is that we do the initial assessment part so that we can rapidly identify the reversible causes of altered mental status and to work on the dangerous conditions which require immediate ICU transfer or even the prompt treatment. And the acute management is to ensure that the blood, oxygen, and glucose, all three vital things to be reaching your brain, to be in simpler terms, to prevent any permanent or additional injury to the brain. So to remember, we all know that ABCD approach is must, and we should always start with ABCD approach to treat all the life-threatening conditions. So always take a sample history and do a secondary examination apart from the neurological presentation. As we all are aware of, A is for airway. So patient may not be able to protect their airways and they may be at a risk of choking. So second part is B for breathing. That is hypoxia can cause AMS. Look for the sign of difficulty in breathing or cyanosis or respiratory rate such that slow and deep respiratory rate is seen in diabetic ketoacidosis or poisoning itself. Circulation, look for BP, pulse, such as the in shock patient, you can have low blood pressure or elevated heart rate. Then disability. For disability, we have two scores. One is Glasgow Coma Scale, which is GCS score, but these are used in trauma patients, specifically in brain trauma patients. And AVPU is a brief score where again the patient is A is alert. Patient is alert without any intervention. V is on verbal stimuli. Patient is responding to your commands and patient is conscious for the surrounding. P is for painful stimuli. That patient is not alert on the by itself or herself, himself. not on verbal stimuli, but if you are putting or applying pain to the patient, then the patient is responsive and you is unresponsive. So basically, this is a brief form of GCS Glasgow Coma Scale, which you can use in periphery or even in the in your emergency setting or casualty setting where patient is presenting to your altered mental status. Always check for the blood glucose using glucometer. That is the fastest thing that you can do, because hypoglycemia as well as hyperglycemia and diabetic ketoacidosis can present with AMS. Always check for pupil, which is just a brief screening thing where very small pupil, as we all are aware of, will suggest a possible opioid overdose or pesticide poisoning. Very dilated or fully dilated, not responding, are mainly like stimulant drugs. And unequal pupil can suggestive of possible head injury, that is suggestive of intracranial pressure which has increased, be it because of stroke, because of tumor, because of any head injury that has happened that is not evident on external examination. Check for strength and sensation. Any weakness or loss of sensation on one half of the body, one half of the limb, can suggestive of possible tumor, bleeding or blockage of the blood vessels, brain infarctions, brain infection also. Generalized muscle weakness can be a possible thing where there is a generalized hypoglycemia, hyperglycemia, hypercalcemia, and even this hypokalemia, periodic paralysis, with or without periodic paralysis, and hypokalemia because of decreased salt intake, dehydration can also present with generalized muscle weakness. Look for any abnormal repetitive movement, shaking of one side or both side of the body, which will suggest you mainly in emergency setting for any movement related emergency or seizure patients to be identified, because seizure patients they are seizing or not. Even non-convulsive status epilepticus patients can present with altered mental status. E is for exposure. Look for causes of AMS, which includes infection, any rashes which are there, any trauma, any injury mark in terms of bite or sting which is there. Check arms for needle marks. If the patient is a destitute, look for any IV drug abusers, the mark, the fibrous tissues. And always remember that altered patient may not or maybe not giving you any history. So look for bystanders, attendants who are coming along, or family members to help you with the baseline status of the patient which he or she was. So let's start with the sample history. First, ask whether what was the current clinical status, is how is it comparable with that of the baseline, whether the patient was like this only, whether there is a sudden deterioration, whether there is a gradual deterioration in this part. And as I have always previously said, also ask family members about the baseline. Then next question is just observe whether there is a difficulty in breathing, because difficulty in breathing in terms of hypoxia, in terms of hypercarbia, any poisoning, any toxic inhalation will present with altered mental status. Then ask whether there was a history of headache along with that of fever, with or without fever, whether this was an acute presentation, subacute presentation, or chronic presentation in terms of meningitis, encephalitis, meningoencephalitis, or there is some toxic inhalation in terms of intoxication, or there is some gaseous inhalation which is there, whether there is associated signs of raised intracranial pressure such as vomiting, or there was preceding history of diarrhea, that will suggest you that this was some infectious thing that has happened and eventually leading to AMS. Headache can indicate the patient is having infection, blood, or tumor. Vomiting without diarrhea can suggest of increased intracranial pressure. Any source of dehydration can cause AMS from poor perfusion to the brain. And vomiting and diarrhea, as we all know, can suggest hypoglycemia, hyperglycemia, or even your decompensated liver patients can present with vomiting and diarrhea. Then next question is whether there is sign of any dizziness, whether there was a blackout or fainting, or patient had fall. So this will suggest you a preceding syncope or pre-syncope phase, which is suggestive of poor perfusion to the brain. And to start with, like, you should ask, how did the symptoms start? Whether it was sudden onset, which is usually a vascular event, whether it was acute to subacute presentation, such as infection etiology, inflammatory etiology, whether it was a chronic thing, which was having, that patient was having it for months or years, and recently there is a worsening, whether there is some change over time, like this was the baseline, but the patient has worsened over time. So always think that rapid onset will make you think about infection, inflammation, bleeding, or some drug or toxin exposure. Gradual onset will make you think about tumor or slow bleeding in the brain. Intermittent onset makes think about some psychiatric illness or seizures. Whether there is any history of fever, which will help you think about any brain infection in terms of bacterial, pyogenic, viral infections, tubercular meningitis, any inflammatory meningitis, which is there. Serious infections in children, elderly will definitely present with AMS. And exposure to prolonged outside, like heat exposure leading to dehydration or heat stroke, can present with AMS also. Some poisons, whether they are inhaled, whether they are ingested, will present with AMS. Some medications, with whether they are taken within the dose range or overdose, will lead to AMS. Always look for any weakness, clumsiness, or difficulty in walking in terms of hemiparesis or paraparesis or just quadriparesis, which is progressed over 2 to 3 days in terms of GBS patients. But GBS patients, if they are peripheral causes, but their manifestation at central terms in terms of brainstem encephalitis, Bickerstaff encephalitis, they will present like the weakness also and altered mental status. Difficulty in walking in terms of imbalance during walking, which is also sudden onset with some confusion. So posterior circulation stroke patients can present like this. Consider always about the stroke, which is a treatable cause if the patient is landing in emergency within your window period. Look for any neck pain or neck stiffness, then always think about some infection in terms of meningitis, meningioencephalitis. Whether there was any recent history of trauma and falls, these things are very important, especially in our elderly patients, because they have lost their muscle tone, they have lost their muscle mass itself, and also there is autonomic disbalance in these patients. So they have trauma, they have just trivial fall, eventually leading to trauma, eventually leading to intracranial bleed also, because these patients already have these diabetes, hypertension, they are on antiplatelet or for some medications like these blood thinners also. So just subtle fall while taking bath in the washroom, they just fell down. So they might just have this history, and eventually they are coming to you with intracranial bleed, large massive bleed with just the altered sensorium, without any weakness, with or without weakness itself. So chronic alcohol intakes, and in elderly, they are more prone for brain bleeding, and they may even not remember that they had sustained any fall or not. If the patient is destitute and there is no history of unwitnessed trauma, but you should always rule out trauma doing NCCT head of that patient. If the patient has any history of depression or recent change in behavior, drug, alcohol use, or psychiatric problems may present with AMS. They might have just taken their medications in overdose because nobody is monitoring them and they are taking it heretic here and there. Consider possibility of suicide attempts in patients who are already on antidepressants or self-harm behavior. Always look for ask if there is anyone else in the same or family member who have similar illnesses, such as gaseous poisoning, such as carbon monoxide in cold climates and indoor heating. You all must have heard of such news in the media. Whether there was any allergy to the medication or any other substance, or recent exposure to known or unknown allergens. Always think of allergic reactions. So eventually it will lead to low blood oxygen level or poor circulation, leading to syncope and shock. Whether there is a recent intake of medication which the patient has not previously taken. If they are carrying, if at all they have it, then collect the medication list. This will be a great help for you. Always look for whether there are multiple drugs that has been taken by the patient, it will eventually help you thinking about whether there was a medication interaction or any side effects, such as pain medications, opioid in terms of morphine, pethidine, heroin will eventually lead to a patient in AMS if taking into overdose. Whether the person had a history of diabetes, because low blood glucose level or even high blood glucose levels in terms of diabetic ketoacidosis. Diabetic ketoacidosis along with that of altered mental status will have increased urine output, increased thirst, fast or deep or Kussmaul breathing. Whether the patient had any history of stroke or heart disease or having high blood pressures. The cardiac arrest or heart attacks can decrease blood flow and oxygen to the brain. Eventually, the heart disease, the patients who have a heart disease in their background, they are always at a risk of stroke because there is always irregular medications. The patient is having difficulty in understanding medication despite you teaching them over and over again. But sometimes the doses are different. What you have advised in patient is taking is entirely different because of the brand name, because of the compliance, because of the monetary issue. They are taking different things. So a lot of patients in our emergency who are coming, they have these previous history of diabetes, hypertension, and heart disease, but they are irregular on medication. So, altered mental status with stroke history may indicate a new stroke or brain bleeding. Like the patient has a stroke on one side, but because it was a cardioembolic stroke, he has stroke on the other side also, or there was inadequate medications or irregular medications. So there is a new stroke that has happened, or just they are taking double the dose. You have advised to reduce the dose, but patient is just taking the same dose. So there might be just history of intraventricular bleed or intracranial bleed in that sense. Old stroke may present with severe illness, and high blood pressure may increase the risk of brain bleed. Whether patient has history of seizure or not, whether they are on, if at all, they were taking regular medications, any medication change or missed dose. This is also very common. All the patients who are taking anti-seizure medications, they are taking by their itself. They are changing doses by themselves. They were not able to understand the dose. They were just going by the color of doses, medications, and they are changing it. They don't have seizures for like 1 to 2 months. They are stopping it by themselves. So all the patients who are coming to with seizures, please always check their medications, not just what you have written on your paper, but also what they are taking, because what they are taking is 80 to 90% different what we are advising. So always think of post-ictal state, whether the patient is not convulsing in front of you, but still always think about the post-ictal stage, whether the patient might have not witnessed by somebody else in the family, but there was convulsion that has already happened, and now patient is confused and landing in your emergency with AMS. Whether there was a history of other infections such as HIV, tuberculosis, whether patient was a previously diagnosed case of any liver or kidney pathology eventually leading into failure. With the history of HIV and tuberculosis, consider infections in and around brain, because these patients are immunocompromised. Despite taking the ATT or even ART, these patients are at a risk of having these brain infections in terms of meningitis, encephalitis, meningoencephalitis. With kidney and liver failure, consider patients who have difficulty in treating, like in clearing toxins and waste because of the compromised hepatorenal system. If the patient was already taking alcohol, how long alcohol was taken, whether there was a history of any other drug abuse, be it oral, be it IV. So alcohol intoxication and alcohol withdrawal both can present with AMS, and they have high risk of head injury and low blood sugar intakes and even dehydrations. The sedatives and opioids itself can cause AMS. In female, definitely don't miss the point whether the patient is pregnant or not, because in these patients in second half or after second trimester, high blood pressures can present, and they can be thus the first presentation of any seizure or convulsion. Help you recognizing pre-eclampsia or eclampsia in these patients. So always take a history of any recent headache in patients who are coming to you with pregnancy and altered status. whether the patient was having decreased oral intake. Always ask these questions in your elderly patients who are neglected or those patients who are taking alcohol. So these patients are at a risk of low blood glucose level and dehydration, which can eventually present to your emergency with AMS. Whether there is a history of recent trauma, either identified or unidentified, or whether there is a recent travel to any place which is epidemic, which is endemic for the cases of encephalitis. Trauma can lead to poor perfusion in eventually AMS and malaria in such recent time when we are expecting monsoon, but it is not there, but still dengue, malaria, chikungunya, these can present with dengue encephalitis. As we all know, there are stages of dengue. Similarly, malaria and chikungunya and JE patients, though we are not encountering in this landscape, but you go to Western UP and those areas, then Japanese encephalitis is also a important consideration. Then whether there is a recent exposure to any sick person, recent bite, chemical exposure, exposure to excessive heat or cold, drug or any alcohol, then sick contact may suggest there is an infection that is spreading over. Then chemical exposure such as pesticides may suggest poisoning, bites may suggest of any envenomation. Exposure to extreme temperatures suggest hyper or hyperthermia. Drug interaction can cause agitation or lethargy. So after these etiologies that you have considered and depending upon the questions that you have asked and your primary diagnosis 1, 2, 3, 4, 5 that you have thought of, just go for the secondary examination. So primary examination is what you have physically seen the patient, how is the mental status in terms of AVPU or GCS, whatever you are doing and you are seeing your patient. Now, just whenever these patients are coming to your emergency, just don't focus on neurological examination per se, just look for other things also, like the skin changes, whether there is some bite marks or not, other systemic examination, including cardiovascular examination, your abdominal examination, respiratory examination, and in females, genitourinary examination should be done. You should not forget that part. So the secondary examination, when you have checked the status of consciousness by AVPU scale or Glasgow-Coma scale in that patient by trauma, I hope we all are aware of GCS. I'm not going again to that point. So after that, what you have segregated your patients or triage your patients in terms of serious or very severe patients, then never forget to check blood glucose in those patients. Check for pupil, whether they are dilated, semi-dilated, equal, unequal, Doll's-eye reflex if it is there. If your patient is oriented, ask for name, how they are, what time it is, and what day of week it is. Check for trauma or any injury, be it at the head, the neck, cervical, spine, or any bruising around the eye, behind the ear, leaking of the clear fluid from nose or mouth or ear. Check for temperature, because it helps you whether there is an infectious cause, whether there is a poisoning, alcohol withdrawal, which eventually leading to change your hormonal levels and eventually causing fever. Hypothermia means the patient can have sepsis, cold exposure, or low hormones such as the thyroid patients. Hypothyroid patients can present with this. Any cold exposure, if there is a stiff neck, then after ruling out a trauma, after ruling out a cervical spine injury, check for a stiff neck. It will help you that patient can have infection, bleeding in the brain, or immobilized spine. If there is a history of trauma, don't do this maneuver in these patients. Secondary examination also include check for strength and sensations to see if there is any intracranial infarct or intracranial bleed leading to hemiparesis or just monoparesis, and do cerebral examination also if a patient is presenting with imbalance while walking. Ask the patient to follow command to test for strength of face, arms and leg, and somehow we always check arms and legs in these patients and forget to check whether the pupillary reactions, the gaze and face strength, because it is an important part in NIHS score, which is done to check for patients who are coming to you with stroke. So always check for facial strength also and compare it with the opposite half of the body. Look for generalized or one-side weakness, which is bleeding or blockage in the vessels, any mass that has recently bled, Consider hypoglycemia, because hypoglycemia and hyperglycemia is a metabolic etiology which can present with monoparesis, paraparesis, hemiparesis, just one shaking of one half of the body, just one limb, myoclonus, generalized seizures, focal seizures, any presentation. So always check RBS using a glucometer, which is always available in the emergency, and consider these metabolic etiology also. Generalized weakness suggests some salt imbalance in terms of calcium, magnesium, sodium, potassium. Check for sign of dehydration, dry mouth, their flaky skin, abnormal skin pinch. Then consider diabetic ketoacidosis. Ask the bystanders or family member whether there was history of diabetes, or the patient, if patient can help, then definitely. Feel the abdomen whether there is an enlarged liver that is suggestive of liver disease in initial phase. Shrunken liver won't be palpable. Check for the skin, whether the skin is cool, pale, or moist skin, then suggest of hypoglycemia. Jaundice can suggest of liver disease. Check for any rash, bite, or sting mark, which suggest of any inflammation. The possible causes of altered mental status in terms of various commutation of signs and symptoms include the rapidly reversible causes of AMS should be the one which we target, because these are the one, if we are treating, we are preventing permanent structural damage or just the permanent damage to the brain. So hypoglycemia, the important one, where patient will be presenting with sweating, seizures or convulsions, or even non-convulsive status epilepticus. You should monitor the blood glucose level, history of diabetes, any malaria, fever with altered behavior, any other severe infection should always be ruled out. Children with any illness, and these patients will have more prone for hypoglycemia. They respond rapidly to glucose administration. Severe dehydration, patient will have sign of poor perfusion such as tachycardia and low blood pressure, abnormal skin pinch, decrease ability to drink fluid, and dry mucous membranes in terms of uh, yes. Then heat stroke or excessive exposure to the heat, can prolonged heat and sun exposure, high body temperature, very warm skin may or may not be sweating. So we had one patient who was working in the field around 40 to 50 degrees for 3 to 4 days. He just presented with 3 days altered behavior with fever, and it was hyperpyrexia, but he had this multiple brainstem bleeds also. Apart from ruling out all the infectious cause, nothing came out positive in terms of whether dengue, malaria. We have ruled out everything. Any other cause also we have ruled out. Eventually, the heat stroke was his diagnosis, and after stabilizing, he improved. Though those bleeds were a new finding that was there in his MRI, but still no other cause were ruled out. So always think about heat stroke and where a patient is healing from. They may have warm skin, but may or may not present with sweating. Hypoxia, be it because of the chronic obstructive airway disease, because of the surroundings where the patient is working in factory or some poisonous areas, poisonous exposure, there is shortness of breath, there is low blood glucose levels, there is cyanosis. Pulse oximeter will help you, and eventually an ABG, which is a quick thing that you can do in your emergency, will help you. Infectious cause of AMS is a very important thing, such as cerebral malaria, where the signs and symptoms includes definitely fever, headache. Rapid malaria test and smear test will come out to be positive. And in area where other people are also presenting with signs of malaria, then you should always think about a patient with altered sensorium and fever to be cerebral malaria as first aid. Eventually, you should always look about encephalitis as other possibilities. Infection and inflammation around the brain, including meningitis, encephalitis, brain abscess, and bleeding, where patient will have fever of few days, 1 to 2 days, 2 to 3 days, or even weeks, along with neck stiffness, rashes which are there, eye pain, sensitivity to the light, headache, non-infectious epidemic areas or exposures, and history of HIV or TB infection that was there. Then severe infection signs and symptoms. Again, the patient is having severe infection is not just pertaining to the central nervous system. It can be other infections which are there, like pneumonia, will eventually leading to the secondary infection, or upper abdomen examinations are very important in these patients, because you just have these patients of having fever for long duration, but you have not touched the abdomen and there is a mass that is there, but patient is very flail. You are not able to see that part. Patient was not complaining of any pain abdomen because of the sensorium. Then look for the peripheral markers such as tachycardia, tachypnea, reduced blood pressure, sign of infection. Some skin infections can be there, cough, crackles in the lung, and some urinary symptoms. Patients who are elderly, who are immunocompromised, patients who are always for long uh, this intraurethral catheter or Foley's catheter is there. There is no other site of infection, but these patients will lead to you. And old patients, particularly in elderly male patients who are having these prostate complaints from periphery, they are getting inserted Foley's and they just come to you with altered sensorium. You have checked the sodium, you have checked potassium, you have checked calcium, everything, metabolic causes. There is no history of COPD. Then once you have ruled out, you have checked that the urine RM urine culture is suggestive of pus cells, field full of pus cells. Once you treat the secondary, this complicated UTI in these patients, your patient is fine. So never forget the urinary infection as a cause of AMS. Rabies, though uncommon, the patient can have very typical agitation, hydrophobia, drooling of saliva, weakness, and history of rabid animal bite. The metabolic causes of AMS, apart from hypoglycemia, diabetic ketoacidosis is a very important thing which is reversible, where the signs and symptoms include a history of diabetes, rapid and shallow deep breathing, frequent urination or decreased urine output, sweet smelling breath, which I hope we all are seeing, high glucose level in blood and urine, and dehydration. The toxic causes apart from that are external toxins such as drugs and alcohol, or even the withdrawal signs and symptoms of alcohol or drug. Patient might be having a known history of alcohol or drug use, or just the first time. Injection marks in terms of patients who are taking drug or IV drug abusers. Alcohol is acutely intoxicated. Withdrawal patients can have convulsions, just confusions, or tremors, or just tachycardia. Chronic use can present with the cerebral damage and eventually leading to balance problem, confusion, tachycardia. Opioids, acutely intoxicated, will have lethargy, very small pupil, and slow breathing, and withdrawal will present with agitation, sweating, diarrhea, and vomiting. Other drugs may cause large pupil, agitation, sweating, and fever. Pesticide poisoning, there will be a history of exposure or working with pesticides. Pinpoint pupil, diarrhea, vomiting, diaphoresis, helping you to make a diagnosis of organophosphate poisoning, very common, very frequently you must have seen in emergency. The snake bite history will be there, bite mark in setting of any venomous snake, or even scorpion sting can present with this. Edema, blistering of the skin, bruising, hypotension, paralysis, seizures, bleeding from the wound, or unmasked wound can be there. The other toxic causes, apart from the poisoning, some medications which are there, which is their overdose, such as opioids, morphine, and this morphine, heroin, ketamine. Few of the patients come with ketamine. Those patients who are on antidepressants or these medications from psychiatry, they are taking excessive doses in terms of self-harm behavior. So always check the medications which they are taking and the prescribed medications, whether there is some new medication that has been advised or there is a change in the dose that was there. So the OPD slips of these patients will be helpful. Any gaseous poisoning exposure in their history that is consistent with the possible exposure of these patients, and multiple patients will be coming to you with a similar thing, headache, not just headache, the head heaviness, or there is just some change in eye color in terms of some redness or congestion. Just this much will be the complaint. Apart from that, seizure, as we all are aware of, that patient will have a known history of seizure, or this is just the first presentation of seizures where there can or cannot be a tongue bite history or self urination. Gradually improvement will be there. Minute is something that we expect, but there are patients which improve over hours. So one patient coming to with altered mental status with one side weakness. So you have ruled out that patient is not having any intracranial bleed, any infarction. Patient was unattended at home. You don't know the situation. So these patients can have a toad palsy that will improve after hours. If patient is pregnant, then always consider eclampsia. Increased pressure of the brain in terms of trauma, tumor, stroke, or brain and swelling will present with headaches, seizures, convulsions, nausea and vomiting, unequal pupil in terms of anisocoria and weakness of one half of the body, or just dysarthria or speech disturbances. Liver disease, where patient can have a history of alcohol abuse or liver disease, and large abdomen with thin arm, jaundice, hypoglycemia, recurrent episodes. These patients of immunocompromised state always look for any tuberculosis meningitis pictures, because these patients, once you have treated the entire part of acute liver failure, if that is there, or decompensated liver failure, you have treated that part, you're treating on that part, but still patient is not improving, just always warrant a MRI in these patients if the KFT is allowing you, because tubercular meningitis and encephalitis is very common in these patients as a presentation of altered mental status if the primary treatment is not helping. Then patients who have kidney disease will present with high blood pressure depending upon the status of the damage, edema or swelling of the legs, decrease or no urine output, or increase urine output depending upon the severity of CKD. Head trauma history will have visual changes, whether there is diplopia, dual vision, or there is blurring of vision, there is obvious eye damage, there is loss of memory, or there is forgetfulness, there is vomiting, headache, any ear discharge, any difficulty or difference between the two hearing between two ears, history of recent trauma, scalp laceration, which is obvious, or just the bruising on the head, there is blood or clear fluid from the nose, anisocoria, weakness of one side of the body, any seizure, any convulsions, or just a brief transient confusional state that is there. So after summarizing up all the clinical presentation, the possible etiologies which are there, we'll briefly touch the management part of altered mental status. Always consider that you have identified the etiology, but first treat this ABCD part and the life-threatening conditions. The management include, if there is suspected hypoxia, then attach oxygen depending upon whether the nasal prongs oxygen mask helps or just positive pressure ventilation. If your Glasgow Coma Scale indicates that patient is having GCS of less than 8, it an indication of intubation, then go for it. Look for underlying causes simultaneously. If there is suspected hypoglycemia, definitely you treat the hypoglycemia by administering IV glucose. If there is suspected hyperglycemia, then give IV fluids, flush those things, look for ketoacidosis. And if the patient is having suspected fever and altered mental status, then give antibiotics depending upon the etiology that you are suspecting. Then test for malaria, dengue in the endemic areas and the part of the year the patient are landing most of the time. Consider poisoning and anovamation. Treat fever with IV paracetamol or other medications depending upon the etiology. If the suspected hypothermia is there, make the warm environment by applying these radiant warmers, or you have those clothing which are there, remove wet clothing if it is there, warm blankets, and give warm IV fluids. If suspected bleeding or increased pressure is on the there, then they have a set protocol of elevating the head at just 30 degree, not more than that. Then if there is a trauma that is there, then think about spinal immobilization first. Any opioid in overdose or mixed drug overdose, give naloxone by IV or IM, and consider redosing if required. If the patient is actively seizing or there is convulsion, then there is a set protocol, then think about benzodiazepines, long acting, and monitor closely for slow breathing, whether there is a requirement of intubation in those patients or not, whether the patient is having status epilepticus, refractory status epilepticus, or non-convulsive status epilepticus. Place the patient in recovery position, that is on the left lateral, without inserting anything in mouth or anything which is a common practice outside. And if the pregnant female is coming to you with active seizures, then consider eclampsia, which is a medical emergency. Then take help of your OBG colleagues also, arrange for rapid transfer and hand over to their unit. Give magnesium sulfate according to the weight. Monitor closely for magnesium toxicity, hypotension, abnormal heart rhythm, coma, respiratory depression, weakness, confusion, nausea, vomiting, flushing. If suspected alcohol withdrawal with seizures, always check blood glucose, and if needed, then administer lorazepam, that is benzodiazepine. If there is a suspected poisoning or innovation, try to identify the poison, arrange for managing unit and airway. If the pesticide poisoning is suspected, then decontaminate and monitor airway for secretions and treat accordingly. If there is a snake bite, then proper wound management and possible antivenom to be administered. If there is a suspected rabies in these patients, then isolate those patients. Though there is no specific treatment, but unfortunately it is fatal, but still isolation and management part is there. If the patient is agitated or violent, then protect the patient from harming self and surroundings. Ensure the patient is safe and call for help if required. If there is suspected trauma, then assess GCS. And if the patient is actively convulsing, check for ABCD, maintain airway, give oxygen, place the patient on left lateral position. Don't let your patient harm you or surrounding. Check for blood glucose, check for oxygen levels through pulse oximeter, and that proper channel of benzodiazepine following by anticonvulsants, and then eventually anesthesia, and then IVIG or plasmapheresis. That is the treatment protocol for status epilepticus. If your patient fits it, then go for that. If the patient is pregnant, then consider magnesium sulfate. If no response, then benzodiazepine. But this should be with your proper OBG help. So the disposition of the patient depends upon the cause, and some causes may not rapidly correct, or they need management at the hospital. So if you are very at the periphery, just carefully monitor the airway patients and hand over it to the higher authorities. Look for hypoglycemia or opioid overdose. If needed, then treat with naloxone. This is again just the brief approach, where first you do the ABCD, and if you find tachypnea, then look for hypoxia, DKA, and toxic ingestion. Whether there is, if there is a poor perfusion, then look for infection or internal bleeding. If there is a tachycardia, look for, and normal perfusion, look for alcohol withdrawal. Patients who are in coma, look for hypoxia, high or low blood glucose level, diabetic ketoacidosis, or toxic ingestions. Hypoglycemia, always think about infection, some medication side effects such as oral anti-diabetic drugs, or even quinine can present with hypoglycemia. Small pupil, pinpoint pupil with slow, shallow breathing will help you keeping as opioid overdose as the diagnosis. Seizure patients can have abnormal glucose, increase, decrease, any infection, any toxin ingestions, or withdrawal in terms of alcohol or other toxin. If there is a history of wheezing, then severe COPD crisis or chronic obstructive airway disease can present with AMS, especially in those patients who are elderly and previous history of smoking or tobacco intake is there. If there is previous history of diabetes, look for blood glucose levels. Previous history of epilepsy, look for post-ictal confusion, sleepiness, prolonged AMS, or multiple convulsions without awaking in between requires workup for non-convulsive status epilepticus. As we have discussed, exposure to agriculture work or any non-pesticide exposure will help you to make a diagnosis of organophosphate poisoning if there is exposure. Alcohol intake will help you with alcohol withdrawal also, intoxication also. If there is a history of HIV, a patient is on ART, then look for other secondary infections in terms of HIV can present with anything, like it can present with peripheral neuropathy, myopathy, then your spinal cord disorder. It can present just with encephalopathy. It can present with PML also. The medications that you are giving at ART will have their own side effects. Rashes on the abdomen, skin or leg, or bulging fontanelle in pediatric patients will help you to think about meningitis as a possible cause. Fever or hypothermia, as we have discussed, will help you to think infection, toxin, and environmental causes as etiology. And this is just the brief critical actions that you should take. If the patient is having hypoglycemia, then correct glucose, monitor the return of glucose, and timely monitoring. Then opioid overdose, naloxone definitely, monitor need of repeated dose if required. The infections which are primarily of brain or just the secondary infections, IV fluids, antibiotic according to the infection. And severe dehydration, IV fluids, assess for infection and consider DKA. Toxin exposure, if it is there, then consider history and consult the advanced providers if there is any anomation. If there is alcohol withdrawal, consider benzodiazepines, decontaminate the pesticides. Pediatric patients are definitely another patients, but we'll just remove that part. So that's it. I hope this was a very vast topic, but still I tried to cover all the important points that should be considered.
Well, thank you, Dr. Deepika. I understand it is a vast topic, agreed, but you have covered it very well, and most of the aspects you have covered nicely. So if there are any queries, you can type in the chat box. Students, there is something I think in the chat box. Just a second. How to differentiate post-ictal state or true altered sensorium?
How to can the I'm not able to see the questions actually.
How to differentiate post-ictal state or the altered sensorium or true altered sensorium?
Okay, post-ictal state patient, to be very honest, initially few hours of your post-ictal state patients, if there is no previous history of any seizures that you have witnessed or family members or the attendant who came along are there. So these patients, if your patient is in post-ictal state, then these patients will improve with the anti-seizure medications. However, the true altered mental status patients will be there. They have a prolonged course. If there is no intervention, then these patients will remain stay like that. They may worsen, and the post-ictal confusion state patients will improve over time. This is what is the expected course of their progression. But if the altered mental status is because of something else, like because of something else apart from the post-ictal state, then these patients will stay like that, or they may worsen depending upon the etiology.
Well, thank you, Dr. Deepika. I don't think there are any other queries. So there are no queries. Thank you is there. And so thank you so much once again. And this is one of the last sessions. We will have another session next week. And then next week, exactly after 14 days, we will have the examination for the students.
Okay.
So that is it. So thank you so much, Dr. Deepika, and all the candidates who have attended. Thank you so much. Thank you.
Thank you. Thank you all.
We close down the meeting today then.